Welcome everyone to Academic Talks by the AO Spine Youth Club. Today's edition is truly special as it marks the beginning of fruitful collaboration with the AO Spine Knowledge Forums and the Youth Club. We will be diving into the work of the Knowledge Forum on spinal cord injury and exploring some of the most debated aspects of acute spinal cord injury management. Here we have timing of decompression, hemodynamic optimization, and how these principles translate into our clinical practice and training. So joining me today are my colleagues, Angelica.
Hello, my name is Angelica Arce. I'm from Mexico and I'm a senior resident in traumatology and orthopedics in the Institute for Orthopedics Banjica in Belgrade, Serbia.
Yes, and Maria Andrea.
Hi everyone, my name is Maria Andrea Montiel. I'm from Venezuela, but I'm a senior resident in Bogota, Colombia, starting my fellowship on February at Fundación Santa Fe.
Brilliant. So my two colleagues will be leading the discussions, and today we're truly honored to be having with us Professor Kwon, who is the past chairperson of the AO Spine Knowledge Forum on spinal cord injury and one of the world's leading experts in SCI management and translational research. Welcome, Professor Kwon.
Hey, thank you for having me. It's great to be with you.
Thank you, Radez, and welcome again, Professor Kwon. It really is a privilege to have the chance to discuss this topic directly with you. Let's jump into the first question. It is well accepted that the compression should be performed as soon as possible. However, what is the scientific incentive for performing an ultra-early surgery during the late evening or at night, when the surgeon might be fatigued, instead of waiting until the next day when, the same surgeon might be a little bit more rested or another one is available?
And as a brief context for our viewers, according to the Global Spine Journal guidelines, there is no difference in mortality between ultra-early and early surgery in the studies performed or in the rate of neurological deterioration between ultra-early and early surgery.
Yeah, so this is a really, really interesting question because it really kind of comes back to the original concept of like, what is the role of decompressing the spinal cord? I think what you said at the beginning, Angelica, is true that we believe that really the sooner that you can get the spinal cord decompressed, probably the better. And there's really nothing necessarily magical about 24 hours. So something doesn't magically happen physiologically to the spinal cord at 24 hours that makes it unresponsive to surgical decompression. There's probably a pattern or a whole pattern of pathophysiological changes and ischemia and hypoxia that are happening, as the minutes go by with the spinal cord compressed. So, I think the work that Michael Failings has led through the years has I think fairly convincingly demonstrated that there is a role for early surgical decompression, and the time that was kind of defined by that is the 24-hour mark. Everybody is kind of interested in this notion of ultra early surgery, and I think like conceptually it makes a lot of sense that if 24 hours is good, then why wouldn't like 12 hours be better? And if it were you or I, like, would we want our spinal cord, decompressed, at 12 hours versus like waiting another night and having it done, at 24 hours? So, I mean, a couple things. The literature, when we reviewed it at the time for the Global Spine Guidelines, really, people have been exploring this issue, but the definition of what actually entails, ultra early has never really been well defined, and was kind of defined a bit ad hoc by the people that had published in this area, 5 hours, 12 hours, whatever. And so for what we could actually glean in the literature at the time, the definition of ultra early was variable, and then the results were variable. So some people found that it was better or the results were better if you decompressed early. Some people felt that it was no different, and there was actually one that felt it was a bit worse. So the results were a little bit were quite mixed, and it was really for that reason that we felt that there wasn't really a scientific justification to make a recommendation about ultra early surgery. Even though we do feel like there's probably like there's nothing magical about 24 hours as the cutoff. And so in some respects, we think that and I think most surgeons would feel like the sooner likely the better. Now there are two issues that you raise that are really important in this dialogue. One is that, like, does it make sense to, rush a patient to the operating room at, 11 o'clock at night or, 1 in the morning with a tired surgeon? I guess there's a few things with a tired surgeon, with a surgical team that's not that familiar with spine surgery, instrumentation and whatnot, and potentially with a patient that hasn't been necessarily resuscitated, and may have a number of other medical comorbidities. I think one of the things that we've really tried to emphasize is even with the guideline recommendation of early surgery around 24 hours, that this still is a judgment call. There is a lot of clinical judgment that has to go into like the decision about taking somebody to the operating room at an early stage. You might have an elderly patient with a lot of comorbidities or a multi-traumatized patient with a lot of other injuries. And clearly these all need to be considered and taken into effect around the decision, or need to be considered in the decision making about taking somebody for early surgery. So we wouldn't advocate, rushing elderly patient with a lot of comorbidities into the OR if they're going to be really unstable, and maybe not even fit for an anesthetic at that time. But I think the issue of what to do at night when you've got a tired surgeon, or in our experience, we're in a fairly experienced center, but the night shift in the emergency nurse or OR for nursing support and whatnot can sometimes be very unfamiliar with spine, and that can make the surgery a lot more complicated to do. I think these are things that people need to kind of consider on on an individual basis, kind of making an assessment of like their own I guess capacity to do the surgery at night, the team's capacity to do the surgery at night, because I think that does play a role in the decision making. And then finally obviously the patient and whether they can tolerate surgery. I think one of the dangers is that, and we've seen this certainly in our experience, that you think, oh well, we don't really want to start that case at 1 o'clock in the morning. We'll start it at 7, but then something else may come in, and then all of a sudden you're not starting at 7, you're starting at noon. So these are things that I think the surgeon at their own institution needs to kind of weigh. Well, what is like, if I say I'm not going to do this at 1, am I really going to be able to get to the operating room at 6 or 7 or whatever? So those are some of the things that I think you need to weigh. I think there's no question that if you have an unfamiliar team and a tired surgeon, that there's an increased risk of adverse events and whatnot, and so those are things that need to be kind of taken into consideration. And then the final thing that I think is harder to quantify, but is important to conceptualize when we talk about ultra early surgery, is that demonstrating that surgical decompression is good and neurologically beneficial in an ultra early context is actually really hard because of the variability in spontaneous neurological recovery. Because if you do ultra early surgery, that also means that you've done an ultra early baseline examination, and this really clouds the interpretation of whether or not ultra early surgery has helped the patient. As many of you will know from if you talk to patients that suffer a spinal cord injury, and most of us have probably seen patients that have come in with a very mild, maybe an Asia D spinal cord injury that they eventually like walk out of the hospital with. If you ask them how they experienced what they experienced at the time of their injury, everyone will say, I fell off the bike or I fell off the ladder or and the minute I hit the ground, I was completely paralyzed. I couldn't move anything. And everybody experiences this period of complete paralysis, no matter what their level of injury is. And so for the fortunate ones, maybe some of that function begins to come back as they are taken to the hospital, and maybe they start to feel their legs, or maybe they start to move their legs. And by the time you see them, a few hours later, maybe they're a very incomplete injury. But if you assess that patient super early, you would think they're all complete. And that's the fundamental challenge with demonstrating a benefit to surgery in ultra early surgery, is that then you're doing an ultra early examination. And so a patient that you might think at, 4 hours post-injury is a Asia A patient, you take them to the operating room at 5 hours after injury, and maybe they recover. Well, that individual might have actually been a Asia C patient if you would have examined them like 12 hours, 14 hours after their injury. And so we know that like the earlier you do the exam, the more variability there is in how patients ultimately recover. And this unfortunately clouds the interpretation of ultra early surgery. So we did a study a number of years ago where we looked at individuals who were deemed to be, Asia A complete cervical spinal cord injuries, and then looked at, well, what is the recovery like, dependent on when they were actually assigned that Asia A kind of designation. And if you were designated as an Asia A before 4 hours, like between 0 and 4 hours after your injury, then your chances of becoming like an incomplete or recovering some function was like significantly higher than if you were just deemed to be Asia A at, say, 14 hours after injury. So the timing of when that assessment is done plays a role in like what the chances are that somebody will recover. And this unfortunately makes it challenging to interpret whether or not early surgical decompression, ultra early surgical decompression is, beneficial for this group of patients. So that's something that I think people need to kind of keep in mind. And it's one of the reasons why, you hear these cases of these miraculous recoveries after surgery, that, patient taken 3 hours after their injury into the operating room. It's obviously we'd like to consider that, yes, this ultra early surgical decompression was good for that patient, but it's possible that individual might have been better had they, been examined, like if it had just taken longer for them to get to the hospital. So I guess in summary, I think people should realize there's nothing magical about the 24-hour mark. There is probably something physiologically beneficial for the spinal cord to be decompressed, earlier than that. Everybody needs to kind of really carefully assess the patient and their resources for doing surgery in the middle of the night. And that in the big picture, the results of ultra early surgery are always going to be clouded by the ultra early examination and assignment of their baseline neurological impairment.
Thank you very much for that clarification, Doctor. That makes a lot of sense. Now, how do a perioperative hemodynamic management and MAP targets influence neurological recovery? Many centers accept a MAP target within 70 to 95. So why does such a significant variation exist?
Yeah, so I think that there are a couple things that we know about hemodynamic management. I think that if any of you have been in cases where you've used intraoperative neuromonitoring and you've had, let's say you're doing a deformity correction or you're doing, some sort of complex decompressive procedure in which You have motor evoked potentials or somatosensory evoked potentials running, and there's suddenly a decline in the signals. The first step is always to make sure that the blood pressure is augmented and maintained. And oftentimes, the minute that you get that worrisome signal, the anesthetist, the surgeon asks the anesthetist, "Well, make sure the mean arterial pressure is up. Make sure they're not hypertensive." And in many cases, that increase in blood pressure will rectify those changes in intraoperative neuromonitoring. And so we've all experienced how sensitive the spinal cord is to blood pressure and changes in perfusion. And we've all witnessed that, the spinal cord can physiologically change and in some cases improve when you increase the mean arterial pressure. So we all kind of know this and we all understand physiologically that this happens. So then what is the role of MAP augmentation for the traumatized spinal cord? Here we would accept that the literature that links a specific mean arterial pressure target to improve neurology, this link is quite weak, and we have a lot of uncertainty about exactly what should that target be and how much that influences neurological recovery down the road. There's a plethora of literature that sort of describes this, and we did try to summarize that in our guidelines. But as you can see if you read the systematic review that we did, the literature, this relationship between hitting a specific MAP target and improving neurological outcome, this relationship is fairly weak. So we know that the mean arterial pressure and the spinal cord perfusion pressure probably does influence the physiology of the spinal cord, but how exactly to do this in a way that improves neurological outcome in the acute traumatic spinal cord injury is less clear. So when we scan the literature, we see that there is a lot of variability in what people have described as, a specific MAP target that they tried to hit and the ultimate neurological outcome. And this is to some extent why there is great variability in the literature. We felt that, the previous guidelines, which recommended 85 to 90 millimeters of mercury for 7 days, didn't fully capture this uncertainty and variability in the literature, and that people had described other thresholds that had resulted in improved neurological outcome. So I think the guidelines recognize two things. One, the guidelines that we published in 2024 recognize that there is this uncertainty and that the literature is not super strong. And so to say, everybody needs to be at 85 to 90 for 7 days, that just simply, the literature to support that contention just wasn't that strong. So we expanded it a bit, and we provided a 75 to 80 millimeter mercury lower limit. But I think one of the important things we did also is we put a ceiling on it, because the previous guidelines, if people interpreted it as, we'll keep it at least 85 to 90, then without a ceiling, then some patients might have a MAP of 105, 110, or 100. And we felt that there was literature to suggest that really driving somebody's MAP beyond 90 to 95 really did not provide much in the way of neurological benefit and was associated with complications largely related to the vasopressors. And so we did feel like that, number one, potentially a lower threshold could be accepted based on what was available in the literature. And number two, that there actually was a rationale to put kind of an upper limit on it, which is why we put the kind of 90 to 95 millimeter mercury window at the top end. So I think that there are a couple things to glean from that. I think that we all agree that, hypotension is probably bad for the spinal cord. And so having a guideline and a target at least would hopefully prevent you from allowing the patient to become hypotensive for long periods of time. And we saw this in our own institution before we instituted our own kind of local kind of policies around hemodynamics, is that patients could actually spend a long time sitting in our emergency room waiting for surgery with a mean arterial pressure of 65. They're conscious, they're making urine, they're comfortable. The nurses feel like, yeah, they're fine, they're stable, but they've got a really low blood pressure. And they might sit like that for 5 hours waiting for surgery. And so having at least a guideline and a target would, once instituted, would kind of prevent those prolonged periods of hypotension. And we think that there is evidence now about just like the complications of saying, well, you know what? Yeah, we're just going to drive the pressure. We're just going to make sure they never fall below 85. Because I think when you do that, you also get these really high maps. And we think there's probably something that is not beneficial about that. And one of the things I think is important for people to know, and this is actually, was news to me when I learned this quite late in my career, was that, for you and I, we think, okay, well, you give vasopressors and you get their mean arterial pressure to 85 and then off you go. But if you actually watch the blood pressures of these patients, it's actually very hard to keep them at a steady map. Their mean arterial pressure bounces around, and the nurses in the ICU are constantly titrating up and down, and it's actually not like you just dial in, because for us, we leave the orders, well, leave it at, keep their map at a certain level. But the nurses in the ICU are always adjusting because the maps are going up and then they're coming down. And so, we do have to have this recognition that it isn't actually totally straightforward to just keep somebody's map at a specific level. So that's why we've kind of put this range, accepting that, that people do have to be aware that, when it gets to the very upper end of the range, well, then it is going to be the time to start thinking about whether or not there needs to be some titration. Similarly, when things drop to the bottom end of that range, okay, well, now we're starting to, get into the situation where, it could certainly drop below this threshold, and people need to kind of have this awareness around increasing the map. So, titrating map is actually not super straightforward. And you ask any nurse about this, and they're always chasing. It's not easy to just set it and forget it as we think. But I think that's how most of us as clinicians feel. Like, they're like, yeah, we just told the ICU to keep the map at a certain level, and then, but if you actually look at the chart and see what has happened to the map, it really does a lot of bouncing around.
In the same note, one recommendation is for map augmentation for a duration of 3 to 7 days to optimize spinal cord perfusion. How would you justify admitting a patient for 7 days in the ICU for map augmentation if one could theoretically achieve the same result in 3 days and allow earlier transfer to rehabilitation?
The duration is a very interesting question as well. And so, the past guidelines had described, 85 to 90 millimeters mercury for MAP for a total of 7 days. And we instituted that locally in our hospital. And it did create some degree of friction because sometimes at 5 to 7 days, the patient might seem quite stable. And so you inevitably get these questions from the ICU. Well, look, like, do we really need to keep this patient here? Just because we're running their vasopressors, or could they be, transferred out of our ICU? And I don't think there's a hospital in the world where ICU resources are so plentiful that this tension doesn't exist. I think that there's a couple things to know. I mean, the literature around like exactly how long the spinal cord should be supported with hemodynamic management. This literature is similarly kind of weak, and people described durations anywhere from like 1 day all the way out to 7 days. The 7-day window that had been previously kind of recommended was a little bit arbitrary. we know from some of our basic science work that the spinal cord is probably not metabolically normal after 7 days either. So like there's probably a persistent, ischemia that happens even after 7 days. So in some respects, even stopping at 7 days, like one might think like there isn't necessarily a strong scientific rationale for that either. Um, we think that for patients that have severe injuries, like particularly the A and B patients and some ASIA-C patients look quite similar. We do try to keep them maintained for a full 7 days. We think that we accepted in the discussion around the guidelines that this was not happening around the world, wasn't even happening in all centers in Canada, and that and particularly for less severe injuries. ASIA-C, ASIA-D patients, that like keeping some of those in that environment for 7 days seemed excessive at a lot of places. And so this is actually why we added like kind of a range within the guidelines to kind of accept that this, the reality was that, a shorter duration was kind of what a lot of people were doing anyways. Now, I don't necessarily adhere to the notion that, the patients are better off going into rehab at, days 4 till 7 in order to start their rehab versus actually getting their spinal cord hemodynamically supported. Because in a sense, if we're conceptually trying to minimize secondary ischemic damage and whatnot in the spinal cord, then I think I would say, well, I'd rather have that happen during this very acute period of time to hopefully maximize the function that a patient enters into rehab with. So I would not buy necessarily this notion that, well, yeah, I mean, they may be better off going into rehab at day 4. But I totally get that in some institutions, there's a lot of pressure on the ICU beds. And practically whether or not they can hold their patient within the ICU environment for a prolonged period of time. We still advocate for people with the very severe injuries to get a full 7 days, but our ICU is actually happy that we've instituted like a lower or a shorter duration for less severe injuries. Particularly like if you're in ASIA-D, because we used to keep the ASIA-D patients in an intensive care setting for 7 days, and many of those patients are walking around, and so you kind of think, well, is this making any sense? So yes, the duration, I would say we totally get it that ICU resources are always tricky. I think that the argument for shortening the duration is in some respects quite practical. But I wouldn't necessarily think that the justification of, getting somebody to rehab on day 4, versus keeping their spinal cord supported, makes a lot of sense.
Thank you very much for your explanation. Now, Professor, from your vast experience teaching and mentoring around the world, could you please tell us what are the most common mistakes you have seen in residents or that young surgeons make in the acute management of spinal cord injuries? And how do you think that can training address these problems?
I think that probably one of I don't know if it's necessarily, I would say, mistakes, but some of the things that I think I've learned over time, is that to have the perspective that it is actually a really acute and urgent situation. I think that's important. I think that there's growing appreciation for this, but I think in a lot of places, there's been a lot of kind of nihilism about spinal cord injury. There's nothing that can be done. There's nothing really that urgently needs to happen. There's no benefit to doing anything. They're going to be paralyzed, and there's nothing that can be done to change the outcome. I think that shifting this mentality is an important thing for our young surgeons to to realize that there are things that can be done. I think that, early surgery is important. I think managing their hemodynamics is important. I think that the technique in which with which the surgery is done is important. So, if we believe that, so I think there's an attitudinal change that is necessary with our young surgeons. I think that one of the things that I think is important if you're in a setting managing these kinds of patients is that, they're not that common. And so, if you believe that, there is something that you can do to help them with early surgical decompression, then I think it's important that you at your institution are talking and communicating really effectively with the team, with the nursing staff, with the OR staff, with the anesthesiologists, with the ICU people, because it really is a team effort to care for these people. And it's not just a surgical problem. And I find that what I've learned, even in my own experience in my own institution, that if I really want to get somebody to the operating room quickly, then the minute I get off the phone with the physician saying, we're sending down a C5 quadriplegic from skiing accident, then I'm on the phone with the neuroradiologist to warn them that we're going to want to do a stat MRI. I'm on the phone with OR to tell them, like, we have somebody coming down that's going to arrive in the next, couple hours. We're going to do an MRI and we'd like to take them to the operating room. The emergency room nurses and the emerge staff are aware that, okay, we want the patient to get their intravenous lines, their art line, get their hemodynamic status, improved, make sure they're not hypotensive when they're sitting in our emerge. And I think ensuring that, because most of us, I think, we just think about, well, what kind of surgery we're going to do. But I think having, this communication with the staff, really does facilitate the better care and more urgent care. So, we can actually get those patients through emerge, resuscitated into the scanner, into the operating room quickly. And having this kind of communication, I think, is something that is really important for young surgeons as they, they'll go out to a place that they didn't do their training and they start their practice. But to actually, develop those lines of communication so that these are all in place when these situations occur, which, for the most part may only occur a handful of times at an institution. So I think those are so the philosophy of urgency, the communication amongst the team, and all the clinical services that patient will touch. And then I do think that it's important, and this is something that's kind of emerging. So I wouldn't say it's necessarily a mistake, but I think that we've become a lot more kind of cognizant about, how do we ensure if we are going to do early surgery that we actually get the spinal cord decompressed? Because there's a lot of talk about like the timing of surgical decompression, but then there's also the aspect of like, how do we technically ensure that what we have done has indeed decompressed the spinal cord? And I think this aspect is kind of an emerging kind of perspective in spine surgery and one of the things that I think has certainly changed even in our practice is that we're much more, I think, thoughtful about, doing a long posterior multi-level laminectomy to ensure that the spinal cord, has room, for it to swell. It has room rostrocaudally, ensuring that the patient in the cervical spine is lordotic, because that actually kind of helps to expand the intrathecal space and provide more room for the injured spinal cord. So I think all of these are things that I think is, we're starting to become more aware of these issues. And a lot of this work was really pioneered by Bijan Arabi about, and thinking not just about the timing, but also about like the technique for ensuring that the spinal cord is indeed decompressed at the time. I've now, as an orthopedic surgeon, I now use a lot of ultrasound in the operating room to ensure that after I've done my decompression, I can visually check to make sure that the spinal cord is indeed decompressed, floating within a CSF surrounded space.
That's great advice. What recent advances in spinal trauma or spinal cord injury management do you believe will change your clinical practice in the next 5 years?
I think probably the most proximal thing will really be around the techniques of decompression. I think this is something that we're really like now beginning to understand better, that you know, there are different ways in which to surgically address the injured spinal column and spinal cord, where you know the swelling of the spinal cord may result in a spinal cord that's still kind of squished after the injury and after the decompression. And I think being cognizant of this, and then, you know, adjusting the surgical techniques to try to ensure that the spinal cord is indeed decompressed after surgery, I see this as being probably one of the next, you know, really important trends for us in spine surgery over the next 5 years. I think we're learning more about the use of intraoperative ultrasound to really do an intraoperative check to make sure. And the most common, you know, issue here is, let's say you have somebody with a cervical burst fracture. And so there is some retropulsion, but then you've done a long, you know, a posterior decompression and it's stabilization, but you want to know, hey, has the spinal cord, like, is that retropulsed bit of bone, is it still infringing upon the spinal cord? Well, intraoperatively, you can see that, you can check on that with ultrasound, because you'll be able to see whether or not the spinal cord has indeed, you know, floated away from that. And that might actually prompt you to do more decompression, more levels, you know, rostrally or caudally with the decompression, the posterior decompression. Or it might prompt you to then actually finish and flip and do the front, where you'd actually go in and do a decompression and reconstruction of the anterior column. So I think that, you know, I think, you know, it's important to know that there isn't actually a lot of strong evidence necessarily to prove that this improves neurological outcome, although I think there is some very persuasive work that's being done by Bijan and Rabi. But I think that, you know, over the next 5 years, I think that this is going to be the next kind of thing for spine surgeons to really think about, like, how do I technically get the spinal cord decompressed intraoperatively, and ensure that, you know, me getting up in the middle of the night to do the surgery has actually technically accomplished what we wanted to do, which was to get the pressure off of the spinal cord, not just, you know, stabilize the spine and you know, do the surgery. Yeah. So this is a topic that Bijan and Rabi has certainly really, you know, advocated for, not just thinking about the timing, but also like making sure that the spinal cord is decompressed. And I think that this is going to be a growing trend for us in the next 5 years.
Thank you very much.
Professor Kwon, your academic approach to treating patients with acute spinal cord injury, and also the leadership that you show in coordinating different groups to provide the best patient care, is unbelievable. You are a true role model for this field, and we are very grateful to have heard you list your thoughts on it. So truly, thank you. Thank you very much.
Oh, my pleasure. Yeah, my pleasure. As you probably will see going through your career, when you meet you know, people like myself, Dr. Failings, like we're very passionate about this topic, and we think there's a lot that we can do for our patients, and we're always happy to talk about it. So thank you for the invitation to participate.
Of course. Well, thank you for taking the time to share thoughts with us, and also for my co-hosts, Angelica and Maria Andrea, for guiding us through this conversation. So yeah, We are very happy that members will join in and listen to this talk, and we will continue exploring the work of the AO Spine Knowledge Forums in future sessions. Thank you, everyone.
Thank you.